Thank you, Dr. Pal, for inviting me here in this meeting. Now, you have seen excellent demonstration of PCNL a little while back. And when we ask any resident what is an ideal PCN tract, he is not able to correlate it with how different surgeons are able to do punctures differently and still be able to provide such good results. So at a basic level, we need to define whether or not the ideal PCNL tract is actually relevant and how it corroborates with the actual puncture making. So this is what we define the ideal tract as of the current existing literature. It means the straight shortest tract which is along the axis of the calyx. So this is how we define the ideal tract. The puncture along the Brodel's line is now a little bit in a gray zone because we puncture both the anterior calyces as well as the posterior calyces, particularly in the supine PCNL. So what are the limitations of the existing definition of an ideal PCN tract? As I said, it is totally disjointed from the puncture making methods, be it bullseye technique, triangulation technique, step down technique, or any monoplanar technique. The description of ideal PCN tract doesn't match how we actually do the puncture. Another limitation is that it is the definition of an ideal tract is limited in its understanding to the prevention of the puncture related complications. It is not, it doesn't correlate with whether the puncture tract would be able to provide good stone free rate or not, and the good clearance would be available or not. So there is no way that we correlate an ideal puncture to the success of the PCNL procedure. Third thing is that it doesn't explain the impact of length and width of the infundibulum at all. And therefore, there is no scope for tailoring of the tract specific to the patient. So therefore, again, the current definition of an ideal tract stands in deficit. So to upgrade this definition of this ideal tract, we developed a concept of a puncture zone. So what we mean by puncture zone is an imaginary cone, the largest imaginary cone that can fit into any calyx. This defines the ideal puncture zone for that calyx, and any point within on the skin which falls within this cone can actually provide an ideal puncture tract for that particular calyx. And if the calyx is wide, this puncture zone would be wide. If the calyx is narrow or long, the ideal puncture zone available for puncture is going to be narrow. This puncture zone also allows the puncture tract to be correlated to the manipulation zone it is able to provide. So for the puncture zone 1, it provides a corresponding conical area which it can access within the pelvic glacial system. So the puncture zone 1 will provide access to the stone in the red zone, whereas the puncture zone 2 would provide the access to the stone 2. Though the manipulation zone of the puncture zone 2 is going to be less than what is going to be provided by the zone 1. How this puncture zone concept allows for the tailoring of the ideal tract is that if we do the puncture from the edge of this puncture zone, say here from the lower aspect of this puncture zone, the manipulation zone that is going to be provided is going to be directed upwards, whereas within the same puncture zone, same calyx being punctured and the same ideal tract being obtained, the manipulation zone that would be achieved would be providing access to both the stone 1 as well as stone 2. So therefore, with this concept, we are able to tailor make the specific tract which is ideally suited to one particular patient's anatomy or the stone location. So this puncture zone can also vary according to the target or manipulation zone. If the stone that we need to target is in the peripheral calyx, then obviously the puncture zone which fits with the definition of an ideal tract is very wide because we don't need to access the pelvis at all. Whereas if the similar kind of a stone is located in the pelvis, in this particular anatomy, the ideal puncture tract that can be, the tract that can provide complete clearance, the ideal puncture zone would be very narrow. And this concept has already been told to you earlier during this demonstration of the surgeries, that when we access the superior calycial, the manipulation zone that is available within the pelvic calycial system is the largest for the superior calyx. It is midway for the middle calyx, and the lower calyx provides the smallest kind of a manipulation zone that is available within the pelvic calycial system. So how do we actually do the puncture using this concept? What we do is we actually have 6 rings. We initially started using this concept somewhere in 2014, and we have been using this same concept ever since. So we have 6 rings, each at 1 centimeter, 2 centimeter, 3 centimeter, up to 6 centimeter. There are 6 rings, and what we do is based on the initial fluoroscopic imaging and the also corroborating it with the preoperative imaging that we have, be it IVP or a CT urogram. On that, we assess the length and width of the calyx that we want to puncture and the skin calyx distance. So based on that approximation, which the surgeon chooses the ring, and then that ring is placed on the skin, keeping the C-arm in alignment with the direction of the calyx, and then that ring provides the puncture zone. So like in this particular case, in most of the cases we use a ring of about 3 or 4 centimeter. And then once this puncture zone is decided, then the puncture can be tailor-made. Supposingly if we want to access the pelvis or the upper ureter, then the tract would be made more obliquely towards the upper edge of this puncture zone. Whereas if we want to remove a stone which is located in the anterior superior calyx, we would need a more vertical tract, and therefore the puncture would be made somewhere in the lower part of this puncture zone. To improve on this arbitrariness of choosing a ring, we now do it a little bit differently over the last 2-3 years. What we do is, on the fluoroscopy itself, we mark the edges of this puncture zone, keeping the fluoroscopy a little bit aligned. The edge of the calyx is marked with a bullseye technique. With the tip of the needle is kept at the edge of the calyx, and the 4 points are marked. Like here, the superiormost point is first marked, then the inferiormost is marked, then the medialmost, and then the lateralmost. So once we have these 4 points, we can join these 4 points to chalk out the puncture zone that is available for a specific pelvis. So these are some of the examples. Like in this particular case, there is a large inferior calycial stone which is entering into the renal pelvis, along with the posterior inferior stone which is in a smaller calyx, and this was in the middle anterior calyx. So in this particular case, this inferior posterior stone was selected for puncture, and then we marked out these 4 points by keeping this tip of the needle at the edge of the calyx in a little bit caudal alignment of the C-arm, and then the second point would be marked by keeping this tip of the needle with a cranially placed direction of the C-arm. And similarly, the medialmost and the lateral most points would be marked, and then by joining these marks, we would get the puncture zone. So within this puncture zone, we can then choose where to exactly make the puncture. So in this particular case, because we wanted to access the middle anterior calyx, which is somewhat laterally, so we did a puncture in a dead zero position using the bullseye technique. So this was the 0-degree puncture, and finally the complete clearance could be achieved from the single tract. So therefore, there is a scope for improving on the puncture making, and we can tailor make the tract specific to the patient according to the patient's anatomy or the need of the case. So we have been doing these cases over the last 7-8 years using this technique. We have done 136 consecutive cases, and if the time permits, I have some few cases to show. Like in this particular case, this is a multi-horn stag-on, and in this particular case, this middle posterior calyx was chosen for puncture. As you can see, these are long, narrow calyces, and therefore a small puncture zone was available. And in this particular case, we did a puncture in about 5 to 10 degree tilt, because we also wanted to access this middle anterior horn. So therefore, we need to make the puncture accordingly. The puncture was not made in 30 degree. It was made somewhere in the 5 to 10 degree orientation of the C-arm. And complete clearance could be achieved in this case using a single tract only. Now, this is another example, a very complex anatomy of the pelvic ileal system. Here was the stone which is located in the near the POJ, and there was no specific orientation of the pelvic ileal system, as we know, in the upper, mid, or lower tract. So in this case, this upper stone was located in the superior anterior, and there is a tri-radiate kind of a stone here, which was blocking all the calyces which are there. So here, keeping in mind that one tract would be providing clearance to both the POJ stone as well as the superior anterior, the upper puncture was made first, and here again the puncture was made keeping the C-arm in a cranial direction, about 5 to 10 degree tilt, and the second puncture then was made keeping in mind that it has to provide clearance in a tri-radiate fashion. So this puncture was made in a dead 0 degree orientation. So these are some other examples. Again, single tract providing complete clearance in cases with large bulk of stones. So just to conclude, there is always a large ideal puncture zone which is available for every calyx that we want to puncture. And using this particular concept actually allows a specific tailoring of the ideal puncture which can be done for any particular patient. Although the concept of puncturing is still arbitrary and depends upon the surgeon, but it definitely improves upon the existing definition of what we call as a ideal piecemeal pack. Thank you very much.